Good morning and welcome to my lecture series on anesthesiology. Today I am discussing anesthetic considerations pertaining to specific anatomic regions. Head and spinal cord trauma. Any trauma victim with altered consciousness must be considered to have a brain injury. The level of consciousness is assessed by serial Glasgow Coma Scale evaluations. Other signs of brain hemorrhage include the restlessness, convulsion, and cranial nerve dysfunction. As for example, a non-reactive pupil. It is a late and valuable unreliable sign that usually just precedes the brain herniation. Hypotension is rarely due to head injury alone. Patients suspected of sustaining head trauma should not receive any medication that will alter their mental issues or neurologic examination. As for example, anticholinergic induced pupillary dilatation. Brain injuries are often accompanied by increased intracranial pressure from cerebral hemorrhage or edema. Intracranial hypertension is controlled by a combination of fluid restriction, except in the presence of hypovolemic shock, diuretics, aspartame mannitol 0.5 gram per kilogram, barbiturates, and deliberate hypocapnia, that is PaCO2 of 26 to 30 millimeter mercury. This protects the latter two require endotracheal intubation, which also protects against aspiration caused by altered airway reflexes. Hypertension or tachycardia during intubation can be attenuated with intravenous lidocaine or fentanyl. Awake intubation causes a precipitous rise in intracranial pressure. Nasal passage of an endotracheal tube or nasogastric tube in patients with basal skull fracture risks the cubiform palate perforation and cerebrospinal fluid leakage infection. Slight elevation of the head will improve the venous drainage and decrease the intracranial pressure. The role of corticosteroids in head injury is controversial. Most studies have shown either an adverse effect or no benefit. Anesthetic agents that increase the intracranial pressure should be avoided, that is ketamine. Hyperglycemia should also be avoided and treated with insulin if present. Mild hypothermia may prove beneficial in the head-injured patient because of its profound value in preventing ischemia-induced injury. Because autoregulation of cerebral blood flow is usually impaired in areas of brain injury, arterial hypertension can worsen the cerebral edema and increase the intracranial pressure. In addition, episodes of arterial hypotension will cause regional cerebral ischemia. In general, cerebral perfusion pressure, the difference between mean arterial pressure at the level of the brain and the larger of central venous pressure or intracranial pressure should be maintained above 60 milligram, 60 millimeter mercury. Deliberate hypocapnia can improve autoregulation. Patients with severe head injuries are more prone to arterial hypoxemia from pulmonary shunting and ventilation perfusion mismatching. These changes may be due to aspiration, atelectasis, or direct neural effects on the pulmonary vasculature. Intracranial hypertension may predispose patients to pulmonary edema because of an increase in the sympathetic outflow. The degree of physiological derangement following spinal cord injury is proportional to the level of lesion. Great care must be taken to prevent further injury during transportation and intubation. Lesions of the cervical spine may involve the phrenic nerve C3 to C5 and cause apnea. Loss of intercostal function limits the pulmonary reserve and the ability to cough. High thoracic injuries will eliminate the sympathetic innervation of the heart, that is T1 to T4, leading to bradycardia. Acute high spinal cord injury can also cause the spinal shock, a condition characterized by the loss of sympathetic tone in the capacitance and resistance vessels below the level of injury, resulting in hypotension, bradycardia, areflexia, and gastrointestinal atony. In fact, venous attention in the legs is a sign of spinal cord injury. Hypotension in these patients require aggressive fluid therapy tempered by phase tempered by the possibility of pulmonary edema after the acute phase has resolved. Suction in cooling is reportedly safe during the first 48 hours following the injury, but is associated with life-threatening hyperkalemia afterwards. Short-term high-dose corticosteroid therapy with methylprednisolone 30 mg per kilogram followed by 5.4 mg per kilogram per hour for 23 hours improves the neurologic outcome of patients with spinal cord trauma. Autonomic hyperdeprexia is associated with lesions above T5 but is not a problem during acute management. This part comes to an end here. I will come with the next video in my next lecture. Thank you.